Let's start. We call it traffic elbow. That means we have an upper extremity with a lot of fractures. And usually we have our arm outside of the window, especially in the cars, and struck with a passing bicycle. That means you must protect yourself. Don't put it outside of the windows, your elbows, to prevent that kind of injury. Otherwise, we have a treatment. In the past, we have an amputation. We have elbow arthrodesis or non-union with very poor functional results over there. All the floating elbow idea started with a classification in early 80s by Statinsky and Michaelis, who describe a floating elbow in children and especially gives the opportunity to treat the supracondylar humerus fraction combined with forearm fractures. But till then, it was a great question on what is going on with the adults. Because in adults, the floating elbow includes a high-energy trauma, and also there is a huge variety of injuries. Usually the patient felt it outstanding hand with forearm pronated and wrist hyperextended. Recently also I found the incidence of that kind of injury is almost 1.6%. It is too low, but in that kind of injuries we have almost 45% with neuromuscular deficit. Probably we must consider if there is any compartment syndrome, and the upper fracture in our series is close to 52%. For sure we need the X-rays, and if the upper extremity is pulsional, then we must proceed immediately in arteriography. So we must ask that question before we start to treat that kind of situation. It is open or close. The envelope is healthy or not, and for sure we must treat all the fractures. You can use open reduction internal fixation if you can do in all the fractures. Alternative, you have the opportunity to use a nail in the humerus or a radial head or external fixator. And finally, also you have the opportunity to use an arthroplasty. But you must do it immediately because after that you have the best results. There is any space for non-operative treatment. As an example, I give you our series is almost 19 patients, and in that we have only one vascular injury, 10 cases with nerve pulses. We try to explore all the nerves, and only one finally needed tendon transfers. We use our classification. Type 1 it is similar to the children, is the extra-articular fractures. We call it type 1. In type 2, we have partial articular, especially if the articular surface is in the proximal part of antebrachium. We call it type 2A. And the opposite, if we have the physeal fracture in the antebrachium and the intra-articular fracture of distal humerus, we have 2B, and if it is completely intra-articular, we have the type C. We classified our cases, and that's our material. Regarding the post-operative manner, we started immediately the uniplanar exercise, passive and active, the first at least 7 or 10 days, and after 14 weeks, we use the rotational movements. This is from our series. This is the type 1 diaphyseal fracture of humerus and the ulnar and radius. Type 2A with the fracture of the radial head. Also over here there is a concomitant fracture of the distal radius. Another 2A with the olecranon fracture. And this is a type 3. This elbow was outside of the window. We have a problem with the ulnar nerve in that kind of situation. First of all, you must carry on the envelope of the elbow using external fixator. And finally, because there is any articular surface, anything to reconstruct, we use semi-constrained total elbow arthroplasty. And thanks God, also we have no palsy of ulnar nerve. This is our patient. Another guy with the same injury. We reconstruct the epicondyles that give us the opportunity to have ligamentous stability of the elbow and hemiarthroplasty. Choose for this big guy is approximately 196 centimeters, 150 kilos. Instead of interposition arthroplasty, dear President, we also discuss about this solution for this young big adult men. Also, we measure the MEPS and the Calfire score, and we found that our results, it was quite good for that injury, approximately 80%. And we are very lucky because we didn't have any infection or malunion. We have also two delayed unions, 2 cases of delayed unions, and we measure the prognostic factors, and now we can say that the type 1, the extra-articular fractures have much, much better results compared to the completely articular in both scores. A variety of floating elbow is the floating ulnar. Okay, this is a parenthesis. This is really Galeazzi fracture with a dislocation of the elbow. I must say that the Galeazzi fracture is almost 6 to 8% of all the fracture of upper extremity. And the injury around the elbow is approximately 11%. This type of injury is too rare. Even Dr. He present one case, collect all the cases, and have done that classification which shows a Galeazzi fracture with an unstable elbow, with a fracture, with dislocation, with a fracture, or with a concomitant fracture of the elbow. And this is the case of that team. But let's go back to the main idea of floating elbow. We try to collect the data. We have done a systematic review. You know, if you have that condition of 19 or 20, 21 with a lot of COVID, you can work with meta-analysis if you don't operate a lot. So we found that even over here, the treatment, the best treatment is the open reduction internal fixation for both humerus and forearm. and the results is good and excellent, approximately 55%. The half of them have good or excellent results. That means that type of injury is huge. And regarding complication, we have for sure infection, compartment syndrome, amputation, or heterotopic ossification. But the main point is that the non-union existed 61% of all the cases, and the reoperation is approximately 1/3. Finally, I must remind you that you must treat with an operation all that fractures. We must try to do that immediately because otherwise we don't have a good or excellent results. And you must try to avoid especially unlocked nails in the fracture of the humerus. Thank you very much.